In this video, let's discuss the treatment of diabetic ketoacidosis. So for diagnosing DKA, we need three criteria. One, a patient's blood glucose level should be more than or equal to 200. It is because of the insulin deficiency. Second, the ketone should be positive on urine dipstick or urine analysis. It is because of the insulin deficiency, the cells cannot take up the glucose. So our body metabolism shifts to lipid, and the end products of lipid metabolism are ketones. These ketones are lost in the urine. That's why you will be able to see ketonuria, positive ketones, and also some of the ketones are lost in the breath during expiration, acetone. That's why the patient will be having fruity breath. And also these ketones are acidic in nature. That's why when you take ABG of the patient, you can see metabolic acidosis, and the body tries to compensate it. The bicarbonates tries to buffer it, and the patient will be having high anion gap metabolic acidosis with bicarb of less than 15 or 18, less than 15 in children and less than 18 in adult. So this is a diagnostic criteria. To sum it up, blood glucose more than 200, ketones positive, on ABG high anion gap metabolic acidosis with bicarb of less than 18. Now coming to the actual treatment of DKA, here we have to intervene the pathophysiology. Here our patient is in hyperglycemic state. Because of that, his blood osmolarity is increased. To dilute this osmolarity, the patient will be physiologically feeling very thirsty and drinking lot of water. But that is not enough. So there will be a lot of fluid shift into the extracellular component, and this fluid is lost in the urine. So if you do not intervene this process, the patient will have volume depletion and will land into prerenal AKA. So our first and initial step in the management of DKA is to give fluids. So by giving fluids, we can replenish the volume, and also we can decrease the blood glucose level to more than 50 milligram per hour. For example, if a patient is having a blood glucose of 500, after 1 hour of fluids, it can decrease to 450. We have to remember one thing: we should not be giving insulin and fluids together. If you give both of them together, there will be drastic drop in the glucose, so drastic changes in the osmolarity, so then that will lead to fluid shift. For example, in children it can lead to cerebral edema, in adults it can lead to pulmonary edema. These are all the complications. So to prevent that, you should be starting after some time, but it should be started in the same day. The insulin should be started in the same day. But before starting insulin, we have to check the patient's potassium level. If the potassium level is less than 3.5, you have to correct it centrally. And if the potassium level is 3.5 to 5, it looks normal, but it's actually the body is deficient in potassium. It is a paradoxical raised. What happens here is, because of the increased osmolarity, there will be fluid shift into the extracellular component. Along with the fluid, potassium also comes out, and that is why we are able to see 3.5 to 5 potassium, even though the cells are not having any potassium. So without correcting the potassium, what happens if you give insulin? So what happens is, every cell will have the sodium potassium ATPase pump, and that pump is activated by the insulin. So if you give insulin, all the potassium which is present in the serum goes into the cell, and the patient becomes depleted in potassium, and he will land into erythemias. So to prevent that, we should replenish the potassium stores first and then give insulin treatment. So if the potassium is more than 5, you don't need any correction, and you can start insulin when the patient's potassium is more than 3.5, but you should also be correcting the potassium. But if it's less than 3.5, first you have to correct the potassium, then only you have to start the insulin. Now coming to the insulin, it should be started as infusion. So after starting insulin infusions, our patient's blood glucose level will decrease. When it reaches to less than 250, you should be careful about the hypoglycemic attacks. That's why you'll replace the IV fluids to DNS to prevent any hypoglycemic attacks. Okay, that is one thing. And when the patient's hyperglycemic crisis is resoluting, that is his DKA is resoluting, then you can switch the insulin infusion to subcutaneous insulin. But here there is one condition: you should not suddenly stop the insulin infusion and start subcutaneous insulin, because the subcutaneous insulin will take some time for the absorption. And if you suddenly stop the insulin, the patient will land into rebound diabetic ketoacidosis. So to prevent that, to bridge that, you will continue the insulin infusion for 2 more hours even after starting subcutaneous insulin. Okay, and now what is DKA resolution? DKA resolution means a patient will be able to tolerate feeds, their blood glucose will be less than 200, our patient acidotic part will improve, the anionic gap will improve, and the bicarb will also be more than 18. When all these are present, it means the patient's hyperglycemic crisis or DKA is resoluting. So that is about it. And whenever the patient is in severe acidosis, that is the pH less than 7, then you can start the patient on IV sodium bicarbonate. And that's about the treatment of diabetic ketoacidosis. Thank you so much for watching. Thank you.